Welcome to Health Code Blueprint. Today, we're diving into the ICD 10cm guidelines for Chapter 15, Pregnancy, Childbirth, and the Puerperium, covering codes O00 through O9A. Because this chapter is extensive and full of critical rules, we've divided it into two separate presentations. This video covers the foundational guidelines, and the second video will continue with the remaining concepts you need to code Chapter 15 accurately and confidently. In this session, we'll walk through the core definitions and coding principles that guide proper code assignment, sequencing, and specificity. By the end, you'll have a clear roadmap for navigating trimester-based coding, identifying the correct principal diagnosis, applying the in childbirth hierarchy, and distinguishing between pre-existing and pregnancy-related conditions. Disclosure: this presentation is for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Let's begin with one of the most important rules in obstetric coding. Chapter 15 takes priority over all other chapters. Anytime the provider documents that the patient is pregnant and the condition is affecting the pregnancy, your first instinct should be to look for a Chapter 15 code. These codes override body system chapters unless the provider clearly states that the pregnancy is incidental. There is one exception to that rule. If the provider explicitly documents that the pregnancy is incidental, meaning it's not affecting the encounter, the condition, or the treatment, then you assign Z33.1, pregnant state, incidental. And remember, Chapter 15 codes are for the maternal record only. They are never assigned on a newborn chart. Next, let's talk about trimester-based coding. Chapter 15 uses trimester or completed weeks of gestation to determine the correct code. You can assign the trimester based on either the provider's documentation of trimester or the number of completed weeks. The trimester definitions follow standard cutoffs. First trimester, less than 14 weeks. Second trimester, 14 to less than 28 weeks. Third trimester, 28 weeks until delivery. There's a special rule you must always remember. If a code has an in-childbirth option, that code takes priority over the trimester-specific option. So even if the patient is in the third trimester, if the condition is documented during childbirth, you select the in-childbirth code. Obstetric encounters often span multiple days or even multiple trimesters. When a patient is admitted in one trimester and discharged in another, the trimester you assign depends on when the condition developed. If the condition developed during the stay, code the trimester of development. If the condition was pre-existing, code the trimester at the time of admission. When the provider documents something like 39 weeks and 6 days, you only code the completed weeks, in this case, 39 weeks. The days are not included in code assignment. Some Chapter 15 categories require a seventh character to identify which fetus is affected in a multiple gestation. These include categories like O31, O32, O35, O40, O41, O60, O64, and O69. But there are times when you assign the seventh character, 0, meaning, not applicable or unspecified. You use the 0 when it's a single gestation, it's clinically impossible to determine which fetus is affected, documentation is insufficient to identify the fetus. This keeps your coding compliant without over-interpreting the documentation. For routine prenatal care with no complications, the principal diagnosis is Z34, encounter for supervision of normal pregnancy. Key reminders: it is always first listed. It is never used with Chapter 15 complication codes. It applies only during the prenatal period. When the pregnancy is high risk, you assign O09, supervision of high-risk pregnancy, as the first listed diagnosis. Unlike Z34, high-risk supervision codes can be used with Chapter 15 complication codes as secondary diagnoses. But remember, if complications arise during labor, you switch to the appropriate complication codes. O09 is for the prenatal period only. When a pregnant patient is admitted but does not deliver during that stay, the principal diagnosis is the complication that prompted the admission. Examples include preeclampsia, anemia, dehydration. If multiple complications are being treated or monitored, any of them may be sequenced first, as long as it aligns with the reason for admission. When delivery occurs during the admission, sequencing becomes especially important because the principal diagnosis must reflect the true clinical reason for the stay. Here's the logic you'll follow. First, was a C-section performed? If no, the principal diagnosis is simply the condition that prompted the admission. Second, if a C-section was performed, ask, was the patient admitted for the condition that ultimately led to the C-section? If yes, the principal diagnosis is the condition that resulted in the C-section. If no, meaning the C-section happened later for a different reason, the principal diagnosis remains the original reason for admission. This approach ensures your sequencing accurately reflects the provider's intent and the clinical circumstances surrounding the delivery. Chapter 15 includes categories for pre-existing conditions, gestational conditions, and conditions that can be either, depending on documentation. Always code based on what the provider states. If the condition arises during the delivery encounter, postpartum codes may be used alongside pregnancy complication codes. For pre-existing hypertension, coding requires a two-part approach. You'll assign an O10 code to indicate that the hypertension predated the pregnancy, plus a secondary hypertension code from the I10-I15 range to fully describe the underlying condition. If the patient also has hypertensive heart disease or chronic kidney disease, the documentation must support additional detail. In those cases, you'll also assign the specific type of heart failure, when applicable, or the CKD stage, when chronic kidney disease is present. This combination ensures the record reflects both the pregnancy-related impact and the patient's baseline cardiovascular or renal status. For gestational diabetes, code assignment is based entirely on the method of control. The provider's documentation should clearly indicate whether the condition is insulin-controlled, managed with oral hypoglycemics, or diet-controlled. Each of these has its own specific O24.4 subcategory, so accuracy depends on capturing the exact management approach. And here's a key rule to remember. Do not assign Z79 long-term drug use codes with O24.4. The O24.4 code already includes the method of control, so adding a Z79 code would be redundant and non-compliant. When a pregnant patient has HIV, sequencing depends on the clinical scenario. If the admission is for an HIV-related illness, O98.7 is the principal diagnosis, followed by the appropriate HIV code. If the patient is asymptomatic, O98.7 is still the principal diagnosis, followed by Z21, indicating asymptomatic HIV status. This structure ensures the record reflects both the pregnancy-related impact and the patient's HIV status. Fetal conditions are coded only when they change maternal management. That means the fetal finding must lead to a clinical action for the mother, such as additional diagnostic studies, increased monitoring, in utero procedures, or decisions regarding pregnancy termination. If the fetal condition does not influence maternal care, then an O35 or O36 code is not assigned. The key question is always, did this fetal finding change what we did for the mother? When a delivery occurs, an outcome of delivery code, Z37, must be assigned on the maternal record. A few important reminders. A Z37 code is required on every delivery encounter. It is never used on subsequent visits after delivery. And it is never assigned on the newborn record. This code captures the final outcome of the pregnancy and completes the delivery episode. To close out this session, here are the 5 golden rules of obstetric coding, the principles that keep your sequencing accurate and your documentation defensible. Chapter 15 takes priority when the pregnancy affects the encounter. Maternal record only. Never assign these codes to the newborn. Completed weeks only, and remember, in childbirth overrides trimester. The admission condition is principal, unless the C-section override applies. Gestational diabetes includes the control method, no Z79 codes allowed. These 5 rules will guide you through the majority of obstetric coding scenarios. Thank you for joining this session of Health Code Blueprint. This concludes part 1 of the Chapter 15 guidelines. In the next video, we'll continue exploring the remaining rules and real-world scenarios that shape obstetric coding. Keep practicing, stay curious, and continue building your coding confidence one guideline at a time.